own language in medicine, and we get very comfortable with that language. And I actually speak a different language than surgeons. They speak their own language, and sometimes it doesn't translate well to one another. So we have to learn um, to communicate, effectively with our colleagues in different disciplines. So you'll hear different terminology from me, for example, than you might hear from some of the neurosurgeons, for example. But I will try to explain as much as I can as I'm going through my talk. That works.
Great, thank you. Neurophysiologist. For people who don't know, Dr. Silverstein came and talked to us about neurophysiology, and now he's going to be talking about a sleep research study he worked on with Dr. D'Amico, and like neuro mapping sleep and how it relates to motor function. Was that it, Dr. Silverstein, or?
Yeah, I'm just pulling up my shared screen now. Can you guys see this screen?
Not yet.
Okay. Actually, I have to hit share. It usually helps if I do that.
Now we see. Perfect.
Okay. Yeah, so we've been doing some really cool things at Lenox Hill for the last, I don't know, 5 or 6 years now, um, that nobody else in the world is doing. um, so when we talk about speech mapping, typically it's done awake, where the patient undergoes an awake craniotomy. They're awake and we speak to them. I'm going to go through that and show you guys how that's done. But the patient is awake during the surgery, and we talk to them and we stimulate their brain, and we try to put them into, depending on where the tumor is, we want to see where the speech area is. So by stimulating their brain, we're able to put them into speech arrest. We're able to figure out what part of the speech area we're in, because they can't necessarily get the words out, or their words start getting jumbled, or they just go into like a speech arrest. So unfortunately, there are patients that cannot tolerate being awake during surgery. Not all patients can tolerate that. So working on some predicate bench testing that's been done in the field, we started applying targeting the orofacial muscles to patients that are asleep as surrogates for indirect speech function in surgery. So basically mapping a patient's speech area while they're asleep. And I'll go through, there are significant limitations to doing this compared to being awake, but I will go through it all with you. We just published this paper, I want to say a month or so ago, and Dr. D'Amico was one of my co-authors on it, as well as Dr. Ellis and Dr. Bookfar, who I know have spoken to all of you guys, and Dr. Bonda, who's the chief resident now in the neurosurgery program, or I think the co-chief resident in the neurosurgery program at Northwell. So we'll go through it. And like I said, I'm a clinical neurophysiologist in the Department of Neurology at Lenox Hill Hospital. So when we talk about direct cortical stimulation, it's one of the oldest neurophysiological techniques that we still use today. I mean, they were doing it back in the 1870s. The Fritz and Hitzig were basically taking a stimulator and connecting to a battery and electrifying, animal brains and watching contralateral motor movement or muscle movement. Penfield and Bouldry were really the ones that standardized the practice in the 1930s with their publications by stimulating awake patients undergoing craniotomies. And they do what we call today the Penfield method of stimulation, which is a bipolar, long train, low frequency stimulation, meaning we have to keep the stimulation on the brain for a few seconds in order to elicit a motor response or a speech response. And this is done while the patient's awake. Now, prior to the 1990s, there was no way to activate the cortical spinal tracts electrically if the patient was asleep, if they were under anesthesia. Anesthesia inhibits the nervous system, so it prohibits us from getting data. But in the 1990s, Taniguchi, he basically applied a multi-pulse stimulation. And when we mean by multi-pulse stimulation and high frequency is he gave multiple pulses of stimulation before the full depolarization in order to prime the anterior horn of the spinal cord, because the anesthesia saturates in the anterior horn. So if you look at the cartoon here, the animation, so we have our brain here, and here's our cortical spinal tract here, and here's our spinal cord, and this is the anterior horn. So you have your upper motor neuron, and there's a synapse with a lower motor neuron at the anterior horn. Then the impulse goes through the nerve roots, and then to the peripheral nerve, to the muscle, to create a motor response. Well, in order to do that in a patient that's asleep, you have to prime that anterior horn, because this is where that anesthesia is kind of settling and it's making it difficult for us. So a single pulse would not allow us to get a response. And that's what the Penfield method is. It's kind of a single pulse. It's not a train of, or it's not a short train of a stimulation. So it kind of looks like this. So we prime the anterior horn here, and then there's a depolarization, and then we get a response on a computer screen. And if you guys watched my lecture I think it was last week, you saw the reasoning behind why we do this and what we're doing. So as a neurophysiologist, we're in the corner watching basically impulses from the nervous system on a computer screen. We digitize those impulses so we can see it on a computer screen. So in the 1990s, like I said, Taniguchi uh, did this multi-pulse short high frequency short train stimulation, and we were able to do this direct cortical stimulation in anesthetized patients. And what that does is hyperpolarizes motor dendrites. Activating the cortical spinal volley is much easier and faster when the patients are anesthetized. Where the bipolar stimulation, it requires 2 to 4 seconds of stimulation, so more time to elicit a response, which is why this is a much better way to stimulate the brain when the patient's asleep. Historically, the stimulation with prolonged 60 hertz trains is used to map speech area and motor cortex. Historically, we've gotten away from that. We don't do it as often. There still are some surgeons that prefer uh, the Penfield method for motor mapping, even in anesthetized patients. We don't do it at all at Lennox or in my practice at all. I go to multiple facilities. We don't do that technique at all unless the patient is awake, and only for speech. For motor mapping, we always do the Taniguchi method, and which is important because when you stimulate the brain, you're introducing electrical current to the brain, and the prolonged 60 hertz stimulation has a much higher incidence of eliciting an intraoperative seizure, and the Taniguchi method does not. So we have a very, very low rate of seizures that occur in our cases because we don't do the bipolar stimulation. And intraoperative seizures, are not good. We don't want them to happen. It's not something that we want to happen. So it's it's something that we mitigate by using the multi-pulse Taniguchi method. There are two types of brain mapping that we do. We do what's called positive mapping and what's called negative mapping. Positive mapping is where we stimulate an area of the brain, for example, and we get a response from the hand, for example. So this is the motor homunculus here. And let's say we stimulate this part of the brain, we would get a response from our hand muscle. Well, we know that's the hand area. We know that we need to stay away from there. That's a positive mapping. But sometimes the tumor is not necessarily near the motor cortex, and that's okay. We stimulate the brain, we don't get a response. That's good. It means we're nowhere near the motor cortex, and the surgeon can enter the brain to access that tumor without injuring the patient. That's called negative mapping. Um, so when we do direct cortical stimulation, it's used to differentiate between the motor cortex and the sensory cortex. So here's the motor cortex here, the sensory cortex here. We can stimulate and activate muscles, obviously, in the motor cortex. When we stimulate the sensory cortex, we should not get responses. And sometimes you do get responses. There are motor neurons that do live in the sensory cortex. I'm not going to get too crazy into the neurophysiology of it, but there are motor neurons that live in the sensory cortex. So we adjust our settings to ensure that we're getting true positive tests versus a false positives or false negatives. We can identify the different areas of the motor homunculus doing mapping, so um, we can basically stimulate different areas of the motor cortex, and by putting electrodes in different muscles like the tongue or face and the hand, we can identify all of these muscles as we're stimulating. And what I was showing here, this is the motor cortex and this is the sensory cortex here, or the motor cortex and sensory cortex uh, here. And these are different types of stimulators I'm just showing here. Now, in speech cases, when the patient's awake, we can actually elicit speech aphasias by stimulating their uh, parts of their temporal lobe where their speech area lives, whether it's Wernicke's, which is going to be your receptive speech, or your Broca's area, which is your motor speech. We can elicit speech arrest, or we can elicit a Wernicke's aphasia, and we can identify language areas. And again, we still do that today with the Penfield method. We have not deviated from that. And then once we've identified the motor cortex and we've identified speech, we can leave a strip on the brain and functionally monitor the motor system while the patient's having their tumor resected. So we can make sure that no fibers from the motor system are affected as they're taking out tumors. And we do that with these strip electrodes. I'm going to go into more detail and show you guys what that looks like as we go. So when we talk about language, we're really talking about, and there's a lot of different, language is so complex, but I'm going to try and make it as easy as possible here. We have Broca's area, which is going to be our motor, and we have Wernicke's, which is going to be basically our sensory or receptive area. Now, there are association areas in speech, and patients that are bilingual have different layouts of their speech area. So it gets very complicated, but basically, verbal behavior is a lateralized function. Language is most commonly found in the left hemisphere. About 90% of the global population are speech dominant in the left hemisphere. Language does have a motor and sensory component, as I said. The inferior frontal gyrus is of the left frontal lobe is the Broca's area, and then the superior posterior aspect of the temporal lobe is the Wernicke's area. Um, this is the pars apicularis here, and this is going to be an important area for us when we start talking about the asleep speech mapping. Now, Broca's area controls the fluidity of speech. So if you have a lesion in the Broca's area, known as a Broca's aphasia, it'll cause disruption of your speech, mislabeling, uh, di- mild difficulty in auditory comprehension, and non-fluent slow speech. So these are, you know, patients that have the inability to say little words like that have grammatical meaning, like a, like a or the, some, or in. Their speech is very broken. It's arrested. They can't come up with the word. Where a Wernicke's lesion, which is going to be back here, this is speech comprehension, and a Wernicke's lesion is known as a patient that has a deficit has a Wernicke's aphasia, which produces poor speech comprehension and basically the production of meaningless speech. But unlike Broca's aphasia, Wernicke's aphasia is fluent and unlabored. So it sounds like the way I'm speaking to you, however, it makes absolutely no sense. They use function words. Um, they use complex verb tenses, but it just is gibberish. It makes absolutely no sense. So what we do is in awake surgeries, we test the patients prior to the surgery, obviously, because we want to make sure that they're um, whatever their deficit, when they're coming in with a tumor that's involving speech or near their speech area, they may have speech deficits coming into the surgery. Well, we need to find that out beforehand, because if we're testing them intraoperatively, we have to make sure we rule out any potential, false positives when we're doing the testing. So let's say the tumor is living kind of in between here, and they have maybe some mild issues. We test them, and then during the surgery, we'll stimulate these areas and identify the margins of Broca's and or Wernicke's to find out where that area is and hopefully find the safe border to be able to take the tumor out. That's usually the plan in these cases. We want to make sure the patient doesn't wake up with any new onset speech deficits. The whole role of what I do in the operating room is to make sure the patient doesn't wake up with a new onset neurological deficit, and a speech deficit is definitely an issue. So when we talk about language mapping, this is the Ogiman stimulator. This is an old cortical stimulator that is used for speech mapping and motor mapping for that matter. We use 4 to 5 second trains. So basically, we leave this probe on the brain for 4 to 5 seconds, and then we do a biphasic stimulation. And we start about 1.5 milliamps, and we increase in 1 to 2 milliamps up until about 10 milliamps. And we want to try to elicit those speech um, deficits intraoperatively. The presence of speech arrest during stimulation identifies the speech area and allows us to preserve language cortex. It also informs the surgeon of functional boundaries that they're able to work around to preserve during a resection. And recently, subcortical stimulation has been added to the paradigm as well, where we're stimulating subcortical fibers in order to make sure we're away from those white matter tracts or deeper speech area tracts. Now, these techniques allow the neurosurgeons to maximize their lesion resection while minimizing postoperative deficits. And we've been doing this for over 60 years, um, but not all patients with lesions in or near their speech area can tolerate awake brain surgery, which is why we've um, expanded on some novel neurophysiology, clinical neurophysiology that's out there. So part of language mapping is we speak to the patient. Now it depends on the hospital that you're in. This is me many years ago doing some language testing with a patient. This is when I was in Texas, and sometimes the clinical neurophys team can do the entire testing, and sometimes we bring the neuropsych team comes in and does the testing, or speech pathology comes in and does the testing. At Lenox Hill, we have a neuropsych and speech team that comes in and does the testing. So all I do is the surgical neurophysiology aspect of it. Um, so it all depends on the institution that you're working in is who will do the testing. Um, we basically go through the Boston naming test, which is a test that goes through flashcards and different things. And we talk to the patient throughout the procedure. And as the surgeon is stimulating the brain, they speak to us, and we can see if they're having any deficits. And remember, we've already saw them in the before the surgery, so we know what their deficit is coming in, and we've gone through the exact same test that we're doing with them here. So if we're showing them flashcards, if they weren't able to name a flashcard in the when we first evaluated them, we omit that flashcard. We want to make sure that there's no false positives here. This is just a video of us. So this is an interesting case. So I'm just going to pause this here. So we had already done the speech mapping at this point, and the surgeon was resecting the tumor. So in this case, and this was done, I don't know, 13, 14 years ago, I did this case. And like I said, this was in Texas at the time. And this girl, she's a young girl, I think she was like 17 years old, had a big tumor in her speech area. And we gave her a handheld phone, and she was talking to her family in the waiting area, and we were just watching at this point for any kind of you know any kind of speech arrest or anything like that, while the surgeon was taking out the tumor. We've already done all the mapping to find his access to the tumor. Now we're kind of evaluating her as she talks to her family, but at the same time we're also looking at her motor component by having her hold the phone. So like I said, this was done a long time ago, but we're still doing these types of things today. Play this some more, and what you'll see here, and so this, it's kind of hard to see on this video because it's so old, but this is just the tumor being resected here. Here it is there. And then when we come back around, what you'll see is, and like I said, she's talking to her family in the waiting. So here's the Ogyman stimulator. This is one of my colleagues running that. So while I'm testing the patient and talking to them and evaluating them, one of my colleagues is running the Ogyman stimulator and stimulating when the surgeon needs it. And then you can't really see when we go back a little further, you'll see a little bit. We have another machine back here where we have a grid electrode on the brain, and we're looking at EEG, and we're looking at what we call electrocorticography, where we're looking for seizures that could be elicited by stimulating the brain. So this is a whole team effort to do these cases and do them appropriately. And then when we come around, I'm going to pause it here. You kind of see our flashcards here. And I don't know if you can see this. It's a bad angle. This is an old flip phone. This is how old this case was. This was an old flip phone that we would have them use for to tell us what it is, telephone, show us how to use it. These are items for kinesthetic awareness. We had a pen, we had a pencil, we had different types of coins that we would give them, and we would ask them what they were, and we could see if they could differentiate that, because we want to make sure that from a kinesthetic awareness standpoint, that they were intact as well. This is a little more recent. This is probably 4 years or so ago. This is myself with Dr. Bookfar, and we're doing awake craniotomy. This is actually room 3 at Lenox Hill. This is before we moved into the bigger rooms. And here we have a neuropsych team that's actually doing the testing with the patient here. I'm just running the cortical stimulator. This is the newer cortical stimulators now. They're not the same as the Ogyman. These are more updated. What's nice about this machine is with the Ogyman, we had to count to 5. 1, 2, 3, 4, 5. Okay, stimulation off. The new stimulator, we can set the amount of seconds that we want stimulation to be on. So as soon as we hit the on button, the simulation goes to whatever preset seconds we have set up. So whether it be 5 seconds or 4 seconds. And then here I am. So again, this is a team effort. I'm watching electrocorticography here on my screen here, and then I have my colleague here also running the electrocorticography. I'm just watching the same screen here. I have it shared here, so I can run this stimulator here while she's watching for the after discharges. An after discharge is a seizure that happens due to stimulation. In a lot of cases, we're also doing motor stimulation in these cases as well, where we have a strip on the brain. And even though the patient's awake and we can ask them to move, we're also stimulating their motor cortex and evaluating their motor system, because patients do get tired during these procedures when they're awake and they're speaking a lot. So we'll run a motor potential off a strip electrode and look at that electrically to make sure everything is intact. And if something happens, we'll then ask the patient to move for us, and see if it correlates and if it's real. So this moves us to sleep speech mapping, which is kind of the cool new things that we're doing. Sleep speech mapping, awake craniotomy is not always an option for the patient. Patients may be uncooperative. Children definitely have a more difficult time tolerating awake craniotomies. There's a neurophysiologist and researcher by the name of Adrian Delitis, and he did the kind of the bench work for this, for what we're doing. We just brought it into the clinical practice. But he found that the laryngeal muscles, so your vocal cords and the muscles that help with phonation and articulation, have a role in execution of speech and motor speech control. And he found that the Broca's area, the inferior frontal gyrus, which is right here, the pars apicularis, is important for all stages of word encoding and their unification, as well as sending coded commands to M1. And M1 is our motor cortex. So what does that mean? What it means is that there is an indirect functional connection of Broca's area here and M1 for face, mouth, pharynx, and larynx. And basically, when we stimulate the brain, we get two responses on our computer screen. We get the first response, which is known as the short latency response. And short latency because it's the least amount of time it takes to stimulate and then record, and we get that potential, it's time. So the short latency response is a marker for M1. It's a neurophysiological marker for M1, meaning it's a neurophysiological marker for motor cortex. And the second response, which happens later in the timeline, is a long latency response. And that correlates to the pars orbicularis area. So in order to preserve motor speech functionality in a population of patients unable to tolerate awake surgery, we employed this technique where we mapped the lateral motor cortex and inferior frontal gyrus, um, and targeted the muscles, the orofacial muscles, the face, the tongue, and I'll show you the muscles, the cricothyroid, which is a muscle for phonation, and the vocal cords themselves. And again, Delitis was the first one to identify these as neurophysiological markers for speech, and we've just expanded that into our clinical practice. What he found was when Delitis did the research, he did it where the patient was awake. So he stimulated with the bipolar Penfield method and obtained speech arrest. And then he simulated with the Taniguchi method that I described and recorded those muscle potentials from the muscles. He didn't do the face and the tongue. He did the vocal cords and the cricothyroid. And the cricothyroid is kind of right here, anatomically. I don't know if you guys can see that. I can't see there. Right there. You can actually feel it um, right around your trachea here. So basically, he found that where he introduced speech arrest from a motor standpoint, a Broca's aphasia, when he stimulated with Taniguchi, correlated to the cricothyroid and the vocal cords. And he found that when it was a short latency response, it correlated to the motor cortex directly. But when it was that longer latency response, and I'm going to show you guys what that looks like, that it basically correlates to the inferior frontal gyrus, which is right here, the pars orbicularis. A sleep speech map, I just want to make it very clear, it's very limited, and it's only for motor component of speech. We cannot do anything with regards to Wernicke's, at least not yet. We can't, because this is a receptive area, and it's sensory, where and again, it's very limited even with the motor aspect of it. It's really for lesions that are most likely abutting these very specific area, very close to this area, because like I said, speech is very complex and there are multiple areas of speech and so on and so forth. So I'm talking about the short latency responses and long latency responses. So what does that look like on my computer screen? Well, this is a short latency response here. Okay, so you can see, so this is time going across. These are different muscles that we're evaluating, and you can see these two here that I've circled. These are the vocal cords here. So what you're seeing here, this little blip is a response from the vocal cords. You can even see a little hand response here, down here. You can see it's flat, 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 and then there's a response. So you don't have to necessarily understand how to read this stuff or interpret this, but you can see flat and then response. Now, what you're seeing at the front of this is that train stimulus. So that's just artifact. That's that priming of the anterior horn, so to speak, to elicit responses. So that's just artifacts. So then you can see it's flat, and then there's a blip. And these are the responses from the vocal cords. This is a short latency response. So this correlates to M1, lateral M1. When we think about the motor homunculus, the face, the tongue, and the larynx are all over here. And as we go more medially, it's hand, arm, and the legs are going to be the most medial. So we're in this area here in this case, we're probably right on the border of the pars orbicularis and the lateral M1. And when we stimulate, we get an M1 response, the motor cortex response, and then we also get that long latency response from the cricothyroid. So this is a long latency response from the cricothyroid. So this is what it looks like on our computer screen, what we're looking to identify when the patient's asleep, because we know to stay away from these areas because these are areas that correlate to speech per deletus. So this is showing you where we just have long latency responses. So we've identified the pars apicularis in this case specifically. So here you can see it, and again, it's flat until it's not, just to make it as easy. And then here we go on the vocal cords, and you can see all the other muscles don't give any responses. There's nothing. It's completely flat, which is telling you these aren't false positives. These are true positives because they're very specific to the muscles that we're targeting, which is the vocal cords and the cricothyroid. So you can see these are all flat here. All these are different muscles. So this is, for example, these are all leg muscles here, tibialis anterior muscle. This is the extensor digitorum brevis in the foot. This is the abductor hallucis in the foot. This is the muscle on the bottom of your foot. This is a hand muscle. This is your forearms. Here's your biceps and triceps. So you can see they're all completely flat, and there's no responses. There's no responses from the face or the tongue either, but we are getting vocal cords, and we are getting cricothyroid, and both the cricothyroid and the vocal cords are the specific muscles that Deletus describes with regards to a producing speech deficits when he stimulated them awake in those same areas, the pars apicularis and the lateral M1. So in our methods so in this study, it was an IRB approved study, and the patients underwent endotracheal anesthesia. And what that means is that they're asleep and they're under general anesthesia, and they have an endotracheal tube in them, so they can't talk to us, and they're asleep. And I'll explain to you how we access the vocal cords, because that endotracheal tube becomes very important. We did 7 patients. You know, it's not a large cohort. You have to understand, these are not common surgeries. Awake surgery is not common surgery. Awake speech mapping cases. Let alone patients that qualify for a sleep. So this was 7 patients over the course of the last 3 or 4 years that we've done this. And I don't know how many of you, I hope a bunch of you were on my last talk where I spoke about, you know, the role of neuromonitoring and surgical neurophysiology, but we do a multimodal approach. So we're doing multiple diagnostic tests throughout the procedure. And these were the tests that we did. We did somatosensory evoked potentials. We did the transcranial motor evoked potentials. So somatosensory evoked potentials, quick refresher, we stimulate a nerve in the on the limb, and we record by placing electrodes on the scalp like little microphones, and record the sensory path to the brain. Then we did transcranial motor evoked potentials to the limbs. So these are where we stimulate the cranium, and we have needles in different muscles in the limbs, and we record from those limbs. Cortical bulbar motors, that's our cranial nerve motors. So that's our face, our vocal cords, our cricothyroid. It's the limb recordings go through the cortical spinal tract. The face recordings and the orofacial muscles go through the cortical bulbar tract. So that's why we call them cobulb MEPs, cortical bulbar motor potentials. We also do EEG on these cases. We do the phase reversal technique, which helps identify the sensory and motor cortex. It's essentially an SSEP, a somatosensory evoked potential, where we stimulate again from the limb, and then we put a strip on the brain. I'm going to show all this to you. We put a strip on the brain, and we're able to identify the motor cortex versus the sensory cortex, and then direct cortical stimulation, which I've talked a bunch about today. And we did it all with the Taniguchi multi-pulse high frequency stimulation. So in order for to cover the orofacial muscles, for the vocal cords or the vocalis muscles, we used basically an ET tube that has an embedded electrode on it. So here's the ET tube here, and this endotracheal tube. Now, not all endotracheal tubes have this electrode, so this isn't common. This is a specialty device that we use in these specific surgeries. And basically what you have here is you have an endotracheal tube, and where the point where the tube should sit on the vocal cords, there is an electrode that's embedded on it. That's right here. These are connected to these lead wires that plug into our machine. So here it is. This is actually one of our patients here. You can see the endotracheal tube here. And obviously you can't see it sitting on the vocal cords, but this electrode is sitting on the vocal cords. Here's our cricothyroid needles. We have needles in the muscle of the cricothyroid here. Then we also have needles here that are taped down. You can't see them because they're taped, but right under here, needles in the lower face. And then this brown lead, if you can follow this brown lead out, this brown lead is in the tongue of the patient as well. So we have kind of a full orofacial coverage. So vocal cords, cricothyroid muscles, the orsumentalis are facial muscles, so they're the face muscles, and then the tongue. And that's our coverage for all these cases that we do. This is what we target here. So first we did a phase reversal, and this is where the surgeon wants to identify where is the M1 versus where is sensory. So S1 versus M1. We use a subdural electrode. It looks like this. It's numbered. And the surgeon places, I'll play the video, the surgeon places it under the dura, so subdurally on top of the brain. So here, the surgeon placing the strip electrode. And so you can see, it's kind of hard to see here, but the strip electrode, like down here, is numbered, and the surgeon can see the numbers. And then what we do is we stimulate the nerve in the limb, and we record from this strip. When we record from this strip, we have the contacts from the strip plugged into our recording device, basically, and it ends up on our screen looking like this. And what we're looking at here is this upward deflection. This indicates sensory cortex, and this downward deflection indicates motor cortex. It's almost like a mirror image. That's why it's called the phase reversal. So this is telling us that contacts 1 and 2, for example, are over motor cortex. So contacts 1 and 2 on the strip electrode are going, and contacts 1 and 2 are going to be furthest away from the lead wire. So like, for example, this is going to be contacts 5 and 6 over here, and then 1 or 2 are going to be down here. So in this situation, 1 and 2 are motor, and then 3 through 6 are all sensory cortex. So once we have an idea of where our motor cortex is, then we can stimulate that area of the brain. We know what area is motor versus sensory just by doing this little test. And you can see they put the electrode down. So there's contact 6 there and contact 5, and they're pushing it under the skull there subdurally, and then we get to see where we are. So once we identified the central sulcus or the Rolandic fissure with that phase reversal, because that's what that reversal, I'm going to go back one, sorry. That's what this means. It means that the central sulcus or the Rolandic fissure lives right here between contact 2 and contact 3. This is the phase reversal. This is sensory and this is motor. So this right here, correlating to where the strip is where the central sulcus is, which is our differentiator between motor and sensory cortices. So once the Rolandic fissure is identified, then we do direct cortical stimulation from the strip. So we use that same strip before we bring in a probe. We basically take that strip and we unplug it from a recording device and we plug it into a stimulation device. And then we stimulate the brain directly using that strip, using those contacts that we found were to be motor. So contacts in that situation would be contact 1 and 2. We stimulate and we use that to threshold the motor cortex. And I'll explain what that means in 1 second. So we start at 15 milliamps, and if we get an orofacial response, then we reduce our pulses from 5 to 1 because we want to make sure that we're not getting any kind of current spread out to muscles distally. So the way that you prove you have central activation versus peripheral activation, and we want central activation, is if you turn down your pulses to 1 pulse, the response goes away. That's a true cortical bulbar motor neural potential. Because remember what I talked about in the beginning of this lecture, Taniguchi developed a multi-pulse stimulation paradigm because you can't elicit a motor evoked potential in a patient that's anesthetized. And this proves that, because if this was not a motor potential, it would still be here when we went down to a single pulse. So we do this for all our cases to ensure that we are getting true motor responses. And you can see in this case, we have a contact over the entire orofacial area, because we're getting a nice response here. Remember, this is the train response here, the artifact. So that's the response. There's the response. So here's response from the facial muscles. Here's response from the tongue. A little tiny response from the cricothyroid. This is a vocal cord response from the left vocal cords, and a vocal cord response from the right vocal cord. And these are all short latency responses. You don't see any long latency responses here. These are all short latency. So we're on the motor cortex directly, so it makes sense. Once we acquire that motor potential, then what we do is we reduce our stimulus intensity down till it goes away, till that motor response goes away. So what we'll do is, once we have this response, let's say we're at 15 milliamps, we reduce that down to, let's say it goes away at 10 milliamps. So that's our threshold, meaning 11 milliamps is what's needed to elicit a motor response. So then what we'll do is we'll go up by 1 or 2 milliamps from 10. So we want to ensure that when we're stimulating with a handheld probe, that we're not going to get a false positive, meaning we're not, if we're too high with the stimulation, we could potentially cause current spread to areas of the brain that would cause the muscles to respond, which would be a false positive. We want to be as specific as possible when we do this. So again, once we acquire the direct cortical motor potential from the strip, we threshold it down to about 1 or 2 milliamps above motor threshold. And then we use a flush tip probe to stimulate the area at this threshold around the area the surgeon wants to cut into the brain. It's called the cortexectomy site. If we activate any orofacial muscles, or any muscles for that matter, the surgeon knows they have to stay away from that area of the brain. So for example, in this case here, this little green marker, this is speech area that we elicited orofacial muscles to stimulation. So here's our strip electrode that's down away from this area here. We got a motor response from the limbs off the strip here, but then we took a handheld probe and we stimulated the brain, and we got a response from the face here. So what the surgeon does is he puts a marker down. He knows he has to stay away from this area because this is speech. So he stays away from this, and he chooses another trajectory to enter the brain to take the tumor out. He also uses this is where he wanted to go in. He's basing it off navigation, but now he has to change his trajectory in order to access the brain and have the patient wake up with a good outcome. So these were the 7 patients. I know it's a lot of stuff going on here, but these were the 7 patients, the type of surgeries that we did, why we couldn't, the type of diagnosis that they had, why we couldn't do an awake surgery on them, and the different muscles that we activated. And so, and patient 1, the reason why we couldn't do it awake was because the positioning of the patient was a left insula case, and the way the patient was going to be positioned, probably in a kind of a 3/4 prone position, so they're kind of almost on their stomach. That's not conducive to them talking to us. So we were able to do this case. It was a GBM and glioblastoma. We were able to activate and find the vocal cords and the tongue, and the patient had a complete resection and woke up intact to their first 3 follow-ups. The second one was a left temporal. The reason why we couldn't do it awake was they were uncooperative and agitated, and an uncooperative patient doesn't work awake. We were able to activate the facial muscles and the cricothyroid, and they are also intact through all 3 follow-ups. The third patient had a left parietal tumor. It was a metastatic tumor, and they had mental status decline. So again, they couldn't tolerate being awake. We wouldn't be able to test them appropriately. We did activate their vocal cords, and they were intact through all three follow-ups with regards to their speech, they started having extremity weakness at their third follow-up, but that's because of progression of their disease, and maybe some of the treatment that they're undergoing had nothing to do with the surgery itself. The fourth patient also had cognitive dysfunction and mental status decline. We were able to target and map the vocal cords, and again, they were intact through all all their follow-ups. The fifth patient had a status epilepticus, which is a seizure disorder. They would just seize nonstop, so we couldn't do them awake because we wouldn't know if they were seizing versus having a vocal deficit, speech deficit. So in their case, we were able to get a vocal cord recording from them as well, and they were intact through all their follow-ups. The sixth case was a left frontal tumor. It was a cavernous malformation. They had a brain bleed, basically a hemorrhagic lesion. In this case, we were not able to get any um, motors from the vocal cord or any of the orofacial muscles, and that was okay because this was a negative mapping case. Remember, we talked earlier in this lecture about positive mapping versus negative mapping. Positive mapping is when you 100% identify a motor response. Negative mapping is when you don't. And we didn't identify our motor response here, but the surgeon kind of, and this was Dr. Bookvar, he expected not to get anything. He planned to negative map that case, and the patient was intact throughout. So he wasn't expecting to get a response, which is we do that all the time. And then the seventh case was inferior frontal as well. Uh, our preclusion for not doing this patient awake was they had a significant language barrier. They spoke Mandarin. Um, you know, there is some debate whether or not language is uh, a prohibition to doing awake surgery. I will tell you that. I mean, you need not only a translator, but there's so many different aspects to speech, and not just us speaking, but the inflection and the how the cadence is. And so if you don't have somebody that understands that to be able to test them, it makes it a little difficult to do it awake. So in this situation, the patient spoke Mandarin. We did not have the ability to test them awake, so we did it asleep. This was actually Dr. D'Amico's case, and we were able to activate the face, the vocal cords, and the tongue, and they were intact through all of their follow-up as well. So the planned resections proceeded in all the cases. We had no adverse neuromonitoring events occur, and every patient woke up neurologically intact as well as speech intact. Motor language injury was avoided in all patients, included despite significant risk, given the presence of where these tumors lived. Um, our successful mapping of the cortical regions corresponding to each orofacial muscle suggests that this technique may be a viable alternative to the gold standard, which is a wake motor mapping. So to conclude, the language system is extremely complicated. Awake speech mapping should be conducted when able. We're not saying that this is a replacement by any means. The technique we describe is limited to motor speech function specifically, and would not provide benefit for receptive or connective speech area disruption. Importantly, while this series demonstrates potential use of neurophysiologic motor cortex speech mapping for patients who cannot otherwise tolerate awake surgery, we need more study, a prospective cohort, a larger sample size, determine efficacy. We're actually starting that now. Asleep neurophysiological identification of oral facial areas of the motor homunculus may be safe alternative to awake craniotomy for patients with lesions abutting the posterior apicular region and lateral M1 region who cannot tolerate awake craniotomies with intraoperative speech mapping. Some of the new stuff that we're doing is we are going to do our own study where the patients are awake, because we do a fair number of awake surgery as well, and we'll also now add this. Now we won't be able to do the vocal cords in our study, because they'll be awake. We need them speaking to us, but we will target the cricothyroid and see if we can also. We're kind of proving that obviously the Deletus was correct in his test. We're just the first to describe this in a pure clinical practice. And it's really worked well for us. We've had no deficits so far, knock on wood. I mean, that's the whole goal here, but it is limited, and it is, but it's very cool, and we're the only ones in the world doing it. So thank you guys. I guess we have questions. I haven't seen any of the chat going, so I don't know if there's big questions or
I'm
not
Dr. Silverstein.
throughout.
Thank you so much for sharing with us. This is really cool stuff.
Yeah, it was a little more complex than I think than the first lecture. Like I said, we speak our own language, guys, and I try to make it as user friendly as possible. But it's not that easy to make some of this stuff, especially in the world of neurosurgery, user friendly. There's a reason why it's brain surgery.
Yes, correct. I'm glad we had that introduction from you in your other talk. It definitely helped understand what you were talking about more today. I was curious about how you chose which tests you wanted to do, because you have so many different tests. So how do you choose which ones you wanted to do for this study?
Well, so this study, so every case that we do, we have multiple tests that we can choose from, and it really depends on what's at risk during the surgery. So if the it depends on the nervous system structures that are at risk. So for example, we in these cases, we always tend, because they're frontal lesions, so the motor cortex is always at risk. So we always want to have motor evoked potentials. So we're worried about the motor cortex. We do sensory evoked potentials as a global if they for different reasons. So for example, if they injure the motor cortex, and we'll see a decline in our motor potential, we won't see a change in our sensory potential. So it kind of is a fail-safe for us, a troubleshooting method. But also, let's say they hit a vessel and they injure a vessel. Well, now we might see our sensory go away along with our motor, and that tells us that the mechanism of injury is not a motor cortex injury, but there's some kind of vascular compromise going on that we need to address, because the sensory, so there's all different reasons why we choose the test that we choose. In this specific case, obviously, where we want to target the orofacial muscles because that's the speech markers, but we're doing all these other tests because we want to make sure the patient wakes up neurologically intact in general, not just their speech. We want to make sure they're moving everything. Where these tumors are, not just speech, it's also motor, it's also sensory. It depends. We do EEG to make sure they don't have, if they start having a seizure, that we identify that early on, because a lot of stuff that we do is reversible, meaning that if we see an adverse event occur in the patient's nervous system during the surgery, we can intervene and reverse that potential devastating injury, or at least stop the procedure so no more damage occurs. Because like Dr. D'Amico said in his last talk, that deficits definitely occur. We're not 100%, we're not infallible, unfortunately. They do occur, but we're there to mitigate the severity of a deficit, hopefully prevent it completely, but mitigate the severity of it, should it occur.
Got it. Thank you. So let's see. Someone asked you to go back on the slide on the 7 patients diagnosed.
This one?
Yeah. Natalie, why did you want him to go back? Not sure. But until then, Celine asked, how often does the patient's speech function get injured during surgery? And once it's gone, is it gone, or is there a way to get it back?
That's a great question. I don't know the number off the top of my head, what the deficit. It all depends. I mean, these are rare procedures in general, not just the sleep stuff, the awake craniotomy. With good mapping of the speech areas, you should avoid speech deficits pretty well. Do patients still wake up with deficits? I'm sure that happens. Thankfully, it doesn't happen with us, or it hasn't happened, at least in the time that I've been, doing the neuromonitoring with these guys. Recovery of it all depends on the nature of the injury and the mechanism of the injury and how bad the injury is, whether or not they recover or not. How long it takes. A lot of times they'll need speech pathology, and they'll need different types of therapy for that. But that, it's a hard question to answer because there's so many different components that go into it.
Yeah, thank you. Catherine asked, can you explain in the one case why Dr. Boockvar expected to negative map that patient?
Right. So this was a left frontal. Okay. So I'm going to go back and I'm going to bring up the brain. Let me see if I can find a picture of the brain. Let me get a cleaner picture here. Okay. So he was pretty far away, like this, like kind of like in this area here. So he was kind of in front of what we thought speech was. So he didn't think that he would get anything, and he was hoping not to. Now, again, we can just, as of right now, identify this area here and this area here. Well, with that being said, we can't identify other areas of Broca's currently. That's part of what we're going to be doing when we do the awake and the awake study. Is we're going to try to see if we can identify different markers for other areas of Broca's, because Broca's is not just here. It encompasses a wide range. Like I said, if you have patients that are multilingual and their Broca's are spread out, and there's association areas that are correlative to speech. It's the insulates correlated to speech. So there's all different areas of the brain that correlate to speech and speech processing and speech, and articulation and motor function. So part of what we're going to do with our new study is, okay, well, we know this is a marker for speech. We know this is a marker for speech, but can we find other markers for speech in other areas of the brain while they're awake? Now, Dr. Boockvar was kind of in this area here. So when he stimulated, we did not he wasn't close enough to the areas where we would see something. Now, then again, the patient waking up without a deficit, we're thankful. It's a limitation to our study. They may have woken up with a deficit if he entered a part of the Broca's that we couldn't identify. That definitely could have happened. We were fortunate that that did not happen in this case, but he wasn't expecting to get a motor response at all. I hope that answers the question, because he kind of knew he was far away. He just wanted to make sure, because you also have to understand, guys, when there's a tumor in the brain, listen, the brain does not look like this, right? We know that. We've seen enough of these videos now that the brain, let's see if I have, where is it? Sorry, here. So if I play this video, that's what it looks like. You don't know what's going on there. And then now you add a tumor under here, and the tumor can displace fibers, can displace your motor cortex. So even though he fairly thinks that the tumor is far away from motor, what if this tumor shifted things around and all of a sudden motor is way over here for some reason, or for whatever reason? So let's say this shifted the motor cortex, which can definitely happen. That's what he's concerned about, but he was fairly confident that we shouldn't get something, which is why we looked for the negative mapping there. The other lesions where we positive mapped, the lesions were much closer to these areas.
Gotcha. Yeah. She said, thank you. You answered the question well. I thought so too. Fabiola asked, which procedure is safer? Is there a difference between the awake one versus the asleep one in terms of safety?
Awake is the gold standard. There's nothing better to monitor a patient than a patient being awake, right? They can tell you they're moving. They can tell you they're not moving. They can talk to you. So from a safer standpoint, I would imagine awake. But that's not the easiest question to answer, because what we're trying to make the sleep safer, obviously, as safe as it can be. And not all patients can tolerate being awake. So that's also another thing. So what's safe for one patient might not be safe for another patient, because if they can't tolerate it, they can't tolerate it. It doesn't matter. I will tell you, we don't just do awake surgeries for speech, for language mapping. There is an abundance of literature that supports awake surgery with electroneurophysiology while the patients are awake, for low-grade gliomas by the motor cortex. That is shown to be very, very safe Patient's awake. We still map them electrically. We still stimulate them electrically, but they're awake. And I'll tell you a great case study, and we published this a couple of years ago. And this was actually, I don't know how many of you guys watched the Lenox Hill Netflix show, but this case was presented in that in the show. You can actually hear me, calling out muscles as as Dr. Pafar is stimulating the patient. So what happened in that case is the patient was awake, and all of a sudden they said they couldn't move their limbs. They couldn't move their upper limb and they couldn't move their lower limb. And the way this tumor was, the tumor was abutting the motor cortex. So where the tumor was, it was really right here, like right next to the motor cord, not near speech. It had nothing to do with speech in this case. This is all motor, meaning limb motor. And it was abutting the limb here. So all of a sudden, now this was a secondary resection, so it wasn't the patient's first time having surgery. We didn't do the first surgery. He had the surgery done. Patient had surgery done, I think, in Detroit or something, and had a um, kind of a recurrency. So they came in and took out the rest of the tumor. So by the time we got to the edge of the tumor was right along the motor cortex here. As Dr. Pofar was working, he subjectively said, the patient said, I can't move my arm. I can't move my leg. So surgery stopped. We did a surgical pause. And at this point, we didn't have our stripping yet because they knew where the motor cortex was at this point based on the fact the patient had a tumor resection beforehand. So we waited a few minutes and the patient started to get their arm back, meaning started to get function back, started moving it. The leg was coming back a little slowly. So went on with the resection. All of a sudden, can't move his arm and leg again. Okay, let's stimulate the brain. We grabbed the probe and we stimulated the motor cortex, and I was able to map the motor homunculus. We basically went from the arms to the legs by stimulating. So basically we stimulated here, and as we stimulated, I activated the hand, then I activated the arm, and I activated the leg, and I was able to tell, Dr. Bookvar, okay, we have continuity of the cortical spinal tracts. So whatever's happening to this patient, yes, subjectively he can't move, but he should be fine because we have continuity electrically of the cortical spinal tracts. And just so happened, patient woke up completely plegic, meaning he couldn't move one side of his body. He couldn't move the contralateral side of his body. But within a week, he was completely fine and went home, I don't know, a week or 2 weeks later. And again, so that's I think episode 5 on Lenox Hill. So if you guys want to check that out, you can actually see the brain mapping in that case. And we published, it was a case study that we published also as well. But it was pretty cool. And we basically said that because we had continuity electrically, we knew that this patient was going to be okay, basically, even though they couldn't move right after surgery. So kind of just it's reason why we're there.
That's pretty crazy. What's going through your head in moments like that? Like, are you panicking a little bit, or you're just like, I mean, you've been doing this for a long time, so maybe you are just like calm and cool, collected. But
well, you're always calm and cool because that's what you do. But if you're not nervous doing this stuff, then you're not doing it correctly. I mean, you have a patient, and you want to be correct and you want to be right, and you're, at least from my standpoint in the corner, I'm telling a surgeon, hey, this patient might have a deficit, or I'm telling them, no, they don't have a deficit, even though they're presenting with a deficit. I mean, no, don't worry about it. You can go either way, because what happens if a week later they're still, they still have a problem, right? So yeah, it's scary, but you go through years and years of training and doing this stuff, and you have to be confident in what you do. But it's definitely an oh shit moment for sure. I mean, for all of us. I mean, it's an oh shit moment for me when I have to tell the surgeon, oh crap, something's going wrong. The surgeon's going, oh crap, something's going wrong. The anesthesiologist is going, oh crap, something's going wrong. So yeah, but it's funny, we did an awake craniotomy last week. I couldn't personally attend that but one of my colleagues did, and she told me how nervous she was going into it. She hadn't done one in a while, and she was very nervous. And I said, "Good." I said, "You have to be. If you're not nervous going into these cases, then you definitely, you're not doing something right because, um, being nervous, it humbles you. It makes you who you are, makes you human, right? So you have to have some kind of humility going into these, and having an empathy for that patient, so to speak. You know, and I'm nervous every time I go into these cases. It's not, yes, it's another day at the office for us, but it's a patient's life is on the line, and we're part of that, that care. We want to make sure they wake up moving, especially when you tell the patient we're going to take care of you. You want to make sure that happens.
Yeah, you take it very seriously. And yeah, that's part of that is like nerves help with like focus, and it's important. So I get that. This one's an interesting one from Georgia. So she asked for patients who speak a different language. If you're doing an awake surgery on someone who's not English, is they're not their first language, do you have an interpreter come and like, or would that be someone you probably wouldn't perform an awake surgery on?
So at least at Lennox, we have a preclusion for them doing them awake because of that, one of those reasons. Again, some institutions may bring interpreters in. I don't know, but like I said, you have to have an interpreter that can also understand the intricacies of the cadence, because you're looking for, like, when a neuropsychologist or a speech pathologist does language testing, they're evaluating certain things, very specific things that are very specific to speech, and an interpreter might not be able to help you with that because they're not professionals trained in speech pathology. Now you have a speech pathologist that's multilingual, obviously that's the best, but there are languages out there that uh, are not that as common, that people learn, obviously. So I think it would, in with us, it all depends on, number one, do we have a multilingual, neuropsychologist that can do the testing, and number two, if we don't, then all those patients are done asleep with us.
Got it. That makes sense. So just curious, where do you see the future of this research going? Like, would you want to continue doing it and just try to get more patients involved in the study? Or
Yeah,
could you be going a different route? Someone asked if this could be used in MS patients to safely remove plaques in the brain. Um,
I mean, I think it's two different things. I think as far as you know the speech component of this, I think that we just have to keep on doing it, and building up our cohort and showing the efficacy of it, getting better statistics on it, and showing, were we were we lucky in 7 patients where we didn't have deficits, or were we truly identifying the areas and mitigating it by identifying those areas and staying away from them? That you just need, 7 patients doesn't tell you that, unfortunately. It's a good stepping point. It's a good starting off point, a jump off point. But you need more patients. And again, these are very, very rare procedures in general, um, so we get as much as we can. With regards to removing plaque from the brain, I mean, that comes down to the neurosurgical teams and where they see their future of us mapping. Yes, if there's eloquent, what we call eloquent cortex, and eloquent cortex is going to be your motor and your sensory and your speech. That's all eloquent cortex. If that's involved with any kind of resection, we can be involved and hopefully ensure the patient wakes up neurologically intact. Doesn't matter what the lesion is, whether it's a plaque lesion or a cerebrovascular lesion or a tumor lesion. So you know as far as resecting stuff for MS, that's outside of my scope from a, but if neurosurgeons were going to do that, and that was something they could do, and it was an area that they were worried about the eloquency of, then yeah, I would be there to make sure that patient woke up neurologically intact.
Very, very cool. What you do is just incredible. And again, I appreciate for people who weren't at your last talk before. I think they can really appreciate that there's a lot there's a whole team in the operating room. It is like, I feel like in your head from like movies or something, you think it's like the doctor and like maybe another doctor and a nurse or something. And
There,
so
yeah,
much work.
there is a whole team of people that are involved in the surgeries, and like, we're not in every surgery, so we're in very specific surgeries, but when we're there, it's us, it's the anesthesiologist, there's a scrub nurse, who's handing the instruments to the surgeon, there's the surgeon, there's a surgeon's assistant, whether it's a physician's assistant or a resident or a fellow. There's sometimes there's x-ray techs in the room. There's cell saver people that spin blood if you need blood transfusions. I mean, there's multiple nurses in the room constantly. There's constantly people, caring for the patient while they're undergoing surgery. And yeah, a lot of people don't realize that. They just think it's very, and we all have a role to play, and we all have our part in the operating room and what we're what we have to do, and we all have a job to do, and and we get it done. We do this day in and day out.
Yeah, very cool. Thank you so much for being here with us. We did get you even longer than an hour today.
Oh, did you?
Yeah. So thank you for that. But I do want to be able to let you go because you started early. So we've had you.
That's okay. I mean, if there's any more questions, I'm more than a lot of people don't know what we do. We're one of those kind of hidden gems in medicine. So I'm more than willing. I mean, I'm more than willing to stay on if people have questions. If not, I can bail out. But I blocked out time to noon. So if if there are questions, I'm more than happy to answer them.
Yeah.
If not, I'm more than happy to go too.
All right. Let me see then. So someone asked if you were to summarize your work in a single sentence, how would you do that? That's tough, but
wow, that's a tough
give it
one.
Go.
Let me think. Somebody asked me, what do you do? I make sure the nervous system stays intact during complex spine and brain surgeries.
Nice. Yes. So whoever asked that, that's your sentence. Anthony asked. So Sky asked, what if the patient is mute and chooses not to speak, or does choose not to speak? How would you know if you've affected the M1?
Well, from a speech standpoint, you wouldn't, right? Because they're mute. So from a speech standpoint, yeah, that's a great question. Yeah, you wouldn't know. I mean, if they're selectively mute, I mean, I don't know how you would know that unless they decided to start speaking, right?
Yeah, yeah, that's a very special case.
But from the M1, when we talk about M1 is not just speech. The lateral M1 is speech.
Mm-hmm.
Just to clarify the anatomy here, this entire area is M1. So the hand area, the arm area, that's all motor cortex. So in a patient that's mute, we might not maybe map their speech, but we will definitely make sure that their limbs are working. If they walk and they do things like that. So we want to make sure that stays intact.
Got it. Thank you. Someone asked, what is the most rewarding part of your work?
The most rewarding part of our work, my work at least, I mean, it's just, being part of that team, being able to care for a patient and to basically be able to help if there's something going wrong. That's very rewarding, that you've if something happens to, because we have to understand, and for those that weren't on my last talk, the surgeons can see the anatomy that they're working around, but they don't know the function of that anatomy. That's my job. My job is to tell them the function of that anatomy, those nervous structures. And if something happens and we can intervene and we can reverse that, that is super rewarding, because it just means that patient, and the patient never knows. They never know that they were on the brink of maybe not walking ever again. That's what's crazy. They never know. They don't know me. They don't know, I meet them right before they go into the operating room. I say good morning. I evaluate them, and then I don't see them again. We don't see them post-operatively, and that's an amazing thing to be able to go home and say, I've changed somebody's life, and they have no idea, and it's great to be able to do that, and it's devastating when something happens and you can't reverse it, and it sits on you, and it's, and not just, obviously the surgeon, but for us as well. Like if I mean, not necessarily that we miss something, but let's say something happens and it's irreversible. That's devastating all around. Because then you start questioning yourself. Did I do something wrong? Did I, did I miss something? Was I not quick enough? Did I not, and a lot of times it's not. Sometimes, like Dr. D'Amico said, there are times that deficits occur, and that's just unfortunately part of what we do. But our role is to mitigate that as best that we can, and I think that's what's rewarding about what we do. And they're kind of behind the scenes. Nobody knows who we are, which is great, and we just
Yeah, that's wild. Like you could be responsible for someone like saving someone from not being able to walk, and like they don't even know it. Like that's wild. Like
yeah.
but you know it, so that's what's important. I feel like. But I'm curious to know, in those cases where you aren't able to reverse something, some type of deficit, how do you recover and move on and continue to do what you do and trust yourself? And
Yeah, I mean, it depends on what happened, right? Was there something out of the control of everything that happened, and there's nothing you can do? I mean, you internalize things, you think about it, and you think, what can I do next time to do better? Can you do something better? Like I said, there are injuries that occur that you just can't. Like we did a case once, and there was I do a lot of cerebrovascular cases, and they're very tricky because if you're doing cerebrovascular cases, obviously their cerebrovascular system is compromised, and whether they've had a stroke or something, or an aneurysm, and we had a case where the patient had an intraoperative stroke, and it was contralateral to where the surgeon was I'm sorry, it was on the ipsilateral side where the surgeon was working, meaning it wasn't the side that he was going to affect, which means completely just the patient had a stroke. And there's nothing we can do. We saw it. We had to tell the surgeon because we saw, hey, something's happening, but he couldn't stop his procedure, and there was nothing to be done at that point. So the patient woke up, and it's devastating. And how you internalize that is you don't forget them, but you also don't let it, you don't dwell on it either, because you have to move on. You have to, and you have to do your job, and you talk about it with your colleagues, and you say, what can you do differently, and what, and you get it out, but stuff that like is out of your control, it's unfortunately it's out of your control.
yeah, and I think if you dwelled on those times when it wasn't a good outcome and let that affect you too much, then that keeps you from helping all these people that you could have helped, and that you like. And sometimes you do need to focus on the cases that did go well, because most of the time that's what happens. So, but that's really tough, and I think that's good to share with the group of like, how do you cope with bad outcomes.
Yeah, and I think the better conversation is with one of the surgeons. Ask them how they, because obviously they're at a whole different level. I'm ancillary to that, right? Because I'm not somebody that would necessarily cause that problem, and it's different how they internalize that, right? If it's under what they're doing. And again, that case that I was talking about, it wasn't the surgeon's fault either. Surgeon didn't do anything wrong. There's nothing any of us could do, and the patient has stroke, but it's devastating. You want your patients waking up intact, and at least going home the same way they came in.
Yeah. On a different note, I'm curious to know what inspired you, and some of the students are also interested, what inspired you to become a physician scientist and do research in addition to all that you do in
Well, I'm not a physician, number one.
yeah.
I am all right. I'm a PhD, a neurophysiologist. So it's I'm a scientist by trade
Gotcha.
that has gone clinical. So I've always been interested in research and propelling my field forward, and you know the field of neurophysiology, surgical neurophysiology. There's so much that we can do to make surgery better, and I want to be a part of that. And I want to make it what I do more specific, so there are better outcomes for patients. So I've always been, I mean, since I started doing, clinical, doing research and publishing and doing things of that nature to propel my field, forward.
Gotcha. Yeah, you've been speaking to us so much about the clinical side. I was like, you're right. You are a researcher first, a scientist first.
Well, I think anybody in the in our fields, whether you're a physician or you're any you're still a scientist, right? Um, and it's it depends on what you want to do with your life. Like I don't work for an academic situation. I do research, basically for the fun of it, because I enjoy doing research. There are some people that just do research, that are true academics, whether you're a physician or not, that they do research because they have to do research. I don't do research because I have to do research. I do research because I enjoy to do research. And like I said, I want to propel the field forward. But yeah, I mean, we do a ton of research. Like I've published just in the past. It was funny. I was talking to the chair of neurology yesterday at Lenox, and with Dr. Ellis, I've published, I think, 6 papers with him in the past two or 3 years. So we're constantly doing work and trying to, promote our field forward, through research. There's a paucity of literature in my field on certain things, because a lot of these cases are very rare. So you don't you don't have a lot of big case series that you can go back and look at. So the only way to get it out there is to take a cool case and maybe publish it, or do a case series and do a prospective study and things of that nature.
Yeah, if you're not doing it, then it's not gonna be seen, which is kind of wild.
Right, and then the field gets stagnant.
Yeah.
Because if you have people that don't want to research, and they're just strictly doing clinical, well, the field doesn't evolve. There's no evolving. So, for example, what I showed you guys here, this is the evolution of surgical neurophysiology, and you're seeing it in real time. Like I said, there's nobody in the world doing this here, and it's great to be part of that ride. To change the lexicon, to change the way people think about things. And you're always gonna have the old guard that won't ever deviate from what they do, but you'll get people that will go, I can't. I remember how this all came about. It's funny. I was working with Dr. Bookvar, I don't know, 4 or 5 years ago, and he came in and he said, Justin, he goes, I'm gonna do this. We're gonna do this case. I would typically do this case awake, but the patient can't tolerate it. So I looked at him and said, well, there is some new research out there about doing this, this, and this that you want to do. He's like, oh, that sounds great. So we just started doing it. And it evolved to this. That's how that all began, saying, okay, well, this wasn't something, I can't take credit for developing this technique, but we're propelling it forward.
Yeah. And I think that's one of the special things about Lenox Hill as well, is Lenox Hill loves being on the cutting edge